So good afternoon, everyone, and welcome to the last session of the day on von Willebrand's disease. It's indeed my pleasure to introduce the first speaker, Dr. Rochelle Winikoff, who almost needs no introduction to this audience. Rochelle is a hematologist in Saint-Justine Hospital in Montreal. She's also an assistant professor of pediatrics at the University of Montreal. Her clinical and research interests are that of bleeding disorders in women, and I think it's safe to say her passion is that. She has been pivotal in helping many of us across the country initiate such clinics. She herself is the clinical director of the Women's Bleeding Disorder in Saint-Justine in Montreal. She's the chair of the Women with Bleeding Disorders subcommittee of the AHCDC. She's also that same chair of or a co-chair in of that subcommittee at the ISTH. She's been a very strong advocate for women with bleeding disorders, and it is my pleasure to introduce her as the first speaker. She'll speak to von Willebrand factor levels in pregnancy and the postpartum period, implications for clinical practice. Rochelle.
Thank you, Vicky, for that very nice introduction, and thank you very much for having me here. It's always very touching and emotional for me to present to this audience, and I've been asked to speak about the implication of von Willebrand factor in pregnancy in the postpartum period. These are first my disclosures. I'll keep them up there for the 30 seconds. I usually start with what I'm going to address, but today I'm going to start with what I won't address. So I will not be getting into details about antenatal testing, anesthesia, the mode of delivery, von Willebrand concentrates, DDAVP, or thromboprophylaxis. So you might say, what is she going to talk about? So this is now the outline. I'm going to be defining a little bit about how I see the problem. I'm going to talk to you a little bit about hemostatic changes in pregnancy and bleeding issues. And of course, I want to just address the controversies around prophylaxis and when prophylaxis might fail, because I think that's really the essence of the title. I have to start off with telling you that every time I do a talk, I go back into the literature, make sure that I haven't had any things uncovered. And I wanted to share with you just at the beginning a little bit of my experience. It was quite a daunting task this time. The columns are purposely hidden here, so A and B, C, and D. I'll tell you one by one what they mean. This is actually a plot of my experience and the percentage of times I ran into different problems when I was going through the literature review. So column A, in about 8% of the time, the author's name was not written properly, so it was impossible to find the reference. Column B represents the number of times that I couldn't find the reference based on the reference that was cited in the article. Anyone want to venture what C might be? The number of times I couldn't find the original article that was cited, there was never an original. So it's really clinical experience, citing clinical experience, and you can go back 5 or 6 times. So 90% of the time I could not find the original article. And D were the number of tables that I had a lot of trouble understanding. Here's a perfect example. At first it looks like quite a benign table, and it looks like every other table you might find in the literature. So patient numbers on the left, cases 1 to 14, factor level. It looks like just an ordinary table at first until you go into the details. So lo and behold, the first thing I notice is that the column that says factor level, I thought it was just the factor level of von Willebrand patients until I realized that the last 4 patients in the chart are actually factor 11 deficient patients. So those factor levels are quoted for factor 11 and not VWD. Next problem, PP here in brackets, I assumed was postpartum in a study on postpartum hemorrhage, but in fact it's actually pre-pregnancy. So some of those levels are pre-pregnancy, some of them are at term. So there's no consistent thing there. And the worst nightmare of all is I was sure this was bleeding time at one point, and it's actually blood transfusion. So just to give you an idea of what kind of nightmare this, I knew postpartum hemorrhage was a really messy business, but this really consolidated that worry. So just to the clinical perspective, so why care about this? So this is a slide from the General Annual Global Survey 2011. I just want to highlight the bars in blue that represent the new diagnoses of von Willebrand with time. And what you can see is that the diagnosis of von Willebrand is on the rise since about 2000 or 2003. And a large part of those patients that are diagnosed are women. Here's called the paradox. So we know that obstetrical gynecological bleeding happens. We know it's common. We know it seems to be overrepresented in women with coagulation disorders. So that's what's represented there. So a large part of those are exacerbated by having an underlying bleeding disorder. But there's a paucity of data here out there, and most of it's extrapolated from the non-pregnant data. So it's very challenging to try to decipher the literature. So I tried to define the problem here. So what do we know about pregnancy? How babies are made. Now, until IVF generation, I was sure I understood. I'm not sure anymore. That a woman's body undergoes physiological changes, I think we know that. That the changes are to optimize conditions for the fetus and the baby, and the changes are also to prevent antepartum and postpartum bleeding. So that part's okay. What are the changes that a woman undergoes during pregnancy? This is a version of an adapted table from this study. And what I just want to highlight is that factor VIII and von Willebrand factor typically go up in pregnancy. So the story seems easy over here. When we look here, there's a group, Sanchez, Luceros et al., had actually tried to define normal ranges of von Willebrand factor in pregnancy. And what this shows is in a cohort of women without a bleeding history, so don't have von Willebrand disease, they're showing you that the factor VIII factor, von Willebrand factor, and the activity hit in the antepartum period maximal levels in the third trimester, and probably preparing for labor and delivery. But the actual peak happens a little bit in the postpartum period. And you can just see some of these ranges of 120, 180%. So that's what happens in women without von Willebrand. In the postpartum period, again in patients without von Willebrand, levels stay high for 2 or 3 days. We have a Canadian study that shows the same results, that until day 4, there's no significant decline in von Willebrand or factor VIII levels until 4 days. It trends towards normal by 1 week and attains normal at 3 weeks. So this is what the normal ranges have been defined in women without von Willebrand. But what we don't know is about von Willebrand is what happens to patients with von Willebrand disease in pregnancy. We don't know the relative contribution of VWD to the overall bleeding risk. So why do we want to treat? Why do we have to treat? We don't know the normal hemostatic levels. We don't know who and when to treat, and we don't know the best way to treat and how long. So this slide here is what I'm trying to illustrate here, and was tried to illustrate by the authors, is the relative contribution of all these risk factors to postpartum hemorrhage. So what we know is that there are many factors that can lead to postpartum hemorrhage, and von Willebrand, indicated with the arrow on the top, is one of the contributing factors. But it has an odds ratio in this study of 1.31 that doesn't attain significance. But actually, if you then consider the patients that were known to have VWD before they gave birth, the odds ratio goes up to 3.4, and the confidence interval becomes significant. So what it's trying to say is that perhaps there's a bias here, because we're including asymptomatic patients in the overall risk, but when you look at the patients that were diagnosed before pregnancy, it's possible that they're the more severe ones, and that those are the ones that are causing us problems. The recommended hemostatic level, 50%. Now, you could notice it's like blinding the number of references that are on that. There's actually not a single reference for that in pregnancy. This is an expert position paper that says you should aim at 50, and that's clearly extrapolated from non-pregnancy. So now we're going to just turn to what are the bleeding issues that we come across in pregnancy. So again, why worry about all of this? So this first graph is an excerpt from a study that was published in 1998, and what it shows on the top graph, factor VIII, on the bottom graph, von Willebrand factor, and what it's showing you is the trend in those levels in the first pregnancy, before pregnancy, all the way to the end of the third trimester, so from left to right. And what you notice is that the patients tend to increase all throughout the terms. But of special note, and this is a quote from the author, we believe that there is a tendency towards complacency in the management of pregnant women with von Willebrand's disease due to an excessive reliance on improvement in the coagulation deficit. So we tend to rely on it normalizing. But if you actually look at these data in detail, what you see is that severe von Willebrand type 1 may not be or any of the von Willebrands may not be normal early in pregnancy. And what you know is that the severe ones may not even be normal at the end of pregnancy. And so if you start less than 15%, you're very unlikely to have normal hemostatic levels at the end of pregnancy. So that's things that people forget about. So you shouldn't rely on necessarily correcting. I like this graph very much, and I'm going to try to show with the pointer here, is that on the left you have a patient without VWD, and it's showing you the point of origin of the von Willebrand factor and as high as it gets at term. This is a patient with type 1 VWD. So they start lower, it's true they go up, but look where they end up compared to somebody without VWD. And of course, the story only gets more complex when you look at the different subtypes, where there might be discrepancies in the amount that it goes up. So I like this study very much. It's a questionnaire study that was handed out to 100 women with von Willebrand and controls. And even though we might criticize retrospective studies, I think it shows several very important things. So one of which is the trend. So if you look at the controls first on the bottom, you can see that antepartum bleeding is actually in around 15% in the first 2 trimesters. But it does decrease in the 3rd trimester, suggesting that there's some protective pro-hemostatic phenomenon going on to protect. And if you look at the row just above it with patients with von Willebrand, the same trend is noted. So it seems that as von Willebrand goes up, there's a more protective effect, possibly on antepartum bleeding. But I will point out that in this study, it was reported at 50% in the 1st trimester, which is very high. So just keeping in mind that hemostatic abnormalities might not be corrected, and if a woman needs antepartum testing or CVS or amniocentesis, you have to remember that she might have not been corrected, and therefore factor replacement is probably required. So antepartum bleeding may occur very early. In one study, the odds ratio of having antepartum bleeding was 10.2 in a series of VW patients versus controls. The good news, though, is compared to rare factor deficiencies, is not all antepartum bleeding in von Willebrand gives miscarriage. And in fact, about 2/3 will go on to have a miscarriage. In the rare factor deficiencies, it's a little bit higher. Now we're just going to talk, that was antepartum bleeding, we're going to say a few words about postpartum bleeding. So why talk about postpartum bleeding? And again, because it's the #1 cause of maternal death worldwide, representing about 25% of all causes of postpartum hemorrhage, with an annual incidence of 140,000 maternal deaths and about 5% of deliveries. And so the question is, what can we do about that? We know that there are all these factors. This table is showing you all the factors. To the left are all the risk factors for postpartum hemorrhage. On the right, showing you the causes. Most of the causes are obstetric in nature, and only the coagulation disorders, whether they're acquired or congenital, is somewhere where we can actually modify something. This is from a study looking at postpartum blood loss in patients that were von Willebrand that were treated versus controls. And you see, despite treatment, they still tend to have greater postpartum blood loss. And that graph is just showing you the medians and the range of blood loss. And it's still somewhat higher than controls despite prophylaxis. In the same study we talked about before with the retrospective questionnaire study and looking at now postpartum hemorrhage, you can see that the primary postpartum hemorrhage is much more frequent in von Willebrand patients and in controls. But when you talk about secondary postpartum hemorrhage, the numbers are actually they're actually lower in the controls, but they're similar to the primary. So women with von Willebrand disease are having primary postpartum hemorrhage and delayed postpartum hemorrhage. In the general population, postpartum hemorrhage, at least the immediate type, is 3 to 5%. So these patients are having a lot more. This is a table I tried to put together with all the different quotes on incidence of primary postpartum hemorrhage and secondary postpartum hemorrhage. And you can see that the incidence varies depending on the methodology used in the study. But I do want to point out two issues. One is that if you refer to the middle of the table where it refers James and Jameson, you can see that this study shows the lowest incidence of primary postpartum hemorrhage in the range of 6% compared to a control population of 4%. In the United States, and I refer you to the guidelines if you're interested, they use very vigorous treatments with a median postpartum treatment days of 6 going out as far as 20 days postpartum. And so I wonder if that discrepancy is because of that. But in general, it's from 20 to 30%. And the second study, the Ramsey study at the end, I just want to point out that in the study of postpartum hemorrhage, none of the type 1 von Willebrand disease bled. They were replaced. And in the type 2, 33% bled. And the numbers of postpartum late hemorrhages were very similar in both type 1 and type 2. So it seems that you're very vigorous in treating up front and less later, and that both patients in type 1 and type 2 are both at risk of delayed postpartum hemorrhage. I'm going to address a few more issues in the detail relating to the factor, because what I've seen in the literature is that the question is, what's protecting you? Is it the factor VIII or is it the von Willebrand factor? And this is another quote from the same author saying, improvements in secondary hemostasis, so meaning factor VIII, appear insufficient to protect against bleeding caused by the primary defect due to a functionally deficient or defective von Willebrand factor antigen. And these are two studies that were done at around the same time, 4 years apart, showing that patients, in the first one, 23 patients with VWD, all the primary postpartum hemorrhages occurred in the type 2 patients, but was independent of factor VIII levels, which were normalized in the 2 out of the 3. These are very small series. In the second study, 14 pregnancies that occurred in 7 patients with VWD. 4 patients had a primary postpartum hemorrhage, another 4 had a secondary, and this was despite normalization of factor VIII. So it suggests that the von Willebrand factor is probably very important in the primary stages of postpartum. So this is the first summary. There's going to be a later summary when I add in the next couple of slides. But I want to stop here and just say, so what we've learned so far is that the severe types of VWD are unlikely to correct in pregnancy. And that includes the severe type 1. So we shouldn't assume that they're going to correct. Low levels of VWD or von Willebrand factor or function at term do predict postpartum hemorrhage. And that PPH or postpartum hemorrhage occurs despite the normalization of factor VIII. We know that it happens more frequently now in patients that have not normalized their profile, and it happens more commonly in type 2 and type 3 patients. And secondary postpartum hemorrhage happens in all von Willebrand subtypes, probably equally. So this is the last little section what I want to go through, and I'm going to run through 4 studies. These are all very small studies with very few patients. But again, the question now I'm going to ask is, okay, these are the risk factors, but does replacement or correcting the deficit help anything? So Foster in 1995 published a series of 31 women unresponsive to DDAVP. That was the inclusion criteria. There were no bleeding in 4 women that were treated with factor concentrates, and there was bleeding in 10 of 26 in whom prophylaxis was not given. And among 14 out of 15 women with type 3, all of whom received prophylaxis, only 1 bled. So it seems that there's a protective effect. Cater published in 1998, at 7 out of 10 women with VWD, primary hemorrhage occurred when factor levels were less than 50% among women receiving no prophylaxis. So when they were borderline 40 to 50, they weren't treated and they bled. No postpartum hemorrhage occurred among 10 women with VWD receiving prophylaxis. And of those with secondary, though the delayed postpartum hemorrhage, 6 out of 8 of them had low factor levels. And Ramzahoy did a similar series of patients showing that there was no primary hemorrhage in type 1 women, but there was a 21% hemorrhage overall in those without prophylaxis. And in the type 2, the incidence of hemorrhage went up when they weren't given prophylaxis. And the last of the series that I could find, and this is an excerpt from Castaman's study in 2011 looking at type 2, show that that 13 out of 15 pregnancies had significant bleeding when they didn't receive prophylaxis because the diagnosis was made after the fact. So I think we have 4 studies here showing that when you don't give prophylaxis, the bleeding's higher. When you give prophylaxis, it's better. And so now the summary that I just showed you on the previous page, I just added in orange here what now I've changed. So the low levels of EW factor at term is a risk factor when no prophylaxis is given. Point 4 is now reads that the primary postpartum hemorrhage mainly occurs in women without normalized profile and who don't receive prophylaxis. And number 6 I've added, which is prophylaxis seems better than no prophylaxis to prevent PPH. The next series of 5 slides, and will be the end in about 5 slides. What I want to show you now is the most recent literature and why this talk was asked of me. And that's because there was a series of publications showing that perhaps our prophylaxis is not sufficient. It works, but the question is maybe not enough. And so this is just, I won't read all of this, but this is a commentary that was published by Peter Coades, who has a big interest in von Willebrand in pregnancy. And he's pointing out the different guidelines that exist, including the Canadian one, which is at the top, which was spearheaded by Christine Demers, who is probably in the room somewhere. But most of them say keep 50 as a safe net for pregnancy and delivery. The Italians seem to use a threshold of 30 to 50, saying don't worry if the levels anything over 30 because they won't bleed. But I think the literature I just showed you shows that might not be the case. This is another publication that was very recent. You can see the date, February 2015. And I'm just going to go back a second. And I'm going to try to read this with you. But at the bottom, what it's showing you is the number of postpartum hemorrhages, severe ones, where the orange arrow is, by factor level. And what you can see is the lower the factor level, the more likely you are to have a severe postpartum hemorrhage. So again, the same trend we've seen before. What it's also showing is that in the type 1 von Willebrand patients, about 37% will have a postpartum hemorrhage, and of those, 5% will be severe. So this is in the type 1 where we just said that we should rely on normalization and that they don't need aggressive treatment. So 5% are still having severe PPH. And the most interesting point here for me is that 19% of patients are still having severe PPH regardless of prophylaxis. So I don't think that the prophylaxis that we're giving is necessarily adequate. Evan Sadler published this. Most of you know the reference, talking about von Willebrand disease as a risk factor for bleeding. And it's true that the risk of bleeding increases as the VWF level decreases, but the relationship is not really strong until you hit very low levels. And so no one really knows between 30 and 50 what the relative contribution of that is towards postpartum hemorrhage. And so, sorry, I skipped that, but he's suggesting that we should use von Willebrand factor as a guide and as a risk factor. In our center, we're very interested to know whether 50 makes a difference at the end of pregnancy versus 200. Like I showed you in patients without VWD, the level of correction at the end of pregnancy goes as high as 300, where somebody with von Willebrand ends up somewhere around 50 to 75 typically. And so we started a 10-year retrospective review trying to assess whether higher degrees of correction in patients with VWD have less bleeding than lower degrees of correction. And the second to last slide is the last study that was published that started all this controversy, and it's a study coming out of the United States of America, where I remind you that prophylaxis is extreme and very, very intense and goes up to 20 days postpartum. And what they conclude is that current strategies don't increase VWF levels to those levels seen in patients without VWD. Now, these graphs are going to be very hard to see, and I can't point over there. I'm going to try my best to show you. But I think if you look at the graph to the left, it's going to be the most telling. And the actual line at the very bottom here is showing you VWD patients that were treated. And the line just above it is VW patients that were not treated. And you can see that despite treatment, these patients don't have levels as high as those that weren't treated. And of course, that's probably just a function of the fact of how severe they were to require therapy in the first place. What's very interesting, though, is how does that translate into clinical worry? And here's the numbers. Some of the blood loss in the treated von Willebrand patients, so despite prophylaxis, was about a mean of 615 milliliters, as high as 780. And compared to the control group was 440, as high as 500. So there's definitely increased blood loss. Another way to show this is with the bar graph. Just one, I think it's going to be the one on the right. So it's this dark one to the furthest right. And that represents the patients with von Willebrand that are treated. And presumably that's because they had lower levels. And what you can see is in the immediate postpartum period, von Willebrand patients, treated or not, bleed about the same. But as you go further out all the way to 6 weeks, you can see that the VWD patients that are treated still are bleeding at 6 weeks later. So there's definitely an implication of undertreating, and this is despite prophylaxis with a median of 6 days. So I'm not here to dogma. I'm not here to tell you what to do. I think we need further studies for sure. I'm just putting up this graph to say that I think that the idea of having 50% as a cutoff for pregnancy is probably not enough. I don't know what the answer is in terms of what we should be aiming, but to keep in mind, I pointed out this graph, and it's published by Sadler, showing that even though von Willebrand, as it goes down, your bleeding risk goes up. If you treat, your thrombosis risk goes up. And so everything's going to be a risk-benefit in deciding how long and how much to treat. So I'm going to end with this slide and saying take-home messages. So primary hemostasis is definitely important in pregnancy and delivery. There's no strong correlation between lower moderate levels and von Willebrand factor and bleeding. And so treat VWD as a risk factor. Optimal levels, duration to protect the postpartum hemorrhage are not known. And it seems that 50 is just not enough. Consider the risk-benefit of treatment versus none, and what I suggest in the meantime, until we know more about this, to have a written treatment plan and be prepared to treat hemorrhage when it does occur. And I'm going to end with a quote from yours truly, that's me. Most bleeding events seem to occur in women with VWD not receiving prophylaxis, but antepartum and postpartum bleeding occurred despite prophylaxis, so further studies are required. Thank you.
think we have time for 1 or 2 questions.
Is there a role for tranexamic acid in these postpartum? I wouldn't do it before delivery, I think, but postpartum, is there a role for that? And then the other question is, despite prophylaxis, if postpartum bleeding does occur, what do you recommend that is then done if they already have high levels? And the issue of platelets, and although you replace von Willebrand factor, it doesn't actually get into platelets, and so these people are still deficient in platelet von Willebrand factor.
So I'll answer probably the second question first, but the question about the late bleeding, for example, nobody really knows what to do there, because if you treat everybody with, for example, factor concentrate for 3 weeks straight in the postpartum period or up to 6 weeks, you're bound to have problems with thrombosis. And the United States group has not reported on that, but you probably will accumulate factor 8 in the postpartum period, and you might run into problems. The idea of giving tranexamic acid, for example, going out for 2 weeks, I know my colleagues in Kingston have a practice, and sometimes they do that, especially we do it in high-risk patients. It might be interesting to use non-specific therapies going out in high-risk patients, going out to cover the risk of the secondary postpartum hemorrhage. In terms of the primary hemorrhage, and at the time of delivery, my feeling is that I think in the future we're going to be able to show, at least in this dose effect study that we're trying to do, is that we should probably not be aiming at 30 or 40 or 50 even. I think we need to aim at first at the time of delivery a bit higher. And so whether that's with DDAVP or concentrate is a whole other issue. So I think that the answer is to minimize primary is to give higher doses combined with the tranexamic acid or not, and to secondary maybe treat far out and use non-specific therapies. That would be my feeling.
Sure. From Calgary, you saw that despite the prophylaxis, there are proportion of patients that bleeds, and the amount of blood loss appeared to be higher than those in the control. What about the proportion of patients on prophylaxis compared to the proportion in the control in terms of bleeding?
In terms of the bleeding?
Yeah, because even normal people may have postpartum bleeding and so on and so forth, and the proportion of those compared to the You might have said that, but I missed it.
Yeah. So the issue, I think your question is how does that compare to the ongoing blood loss in the patients without von Willebrand disease? Yeah. So that last graph was trying to depict that. I can't seem to go back. I don't know if in audiovisual we can just go back 2 slides. It's not allowing me. But the answer is at any time point they bled less. So there is still, it's normal to bleed postpartum, but at any time point they bled less. And actually they bled in a similar way to the VWD patients that didn't get treatment, presumably because they were corrected. So there is still within the first 6 weeks going to be ongoing low-keel blood loss. But the issue is that in the treated, so the more severe von Willebrand's patients, they're bleeding more. I don't know if that answers the question.
I think we're going to have to, unfortunately, end it there because we're running out of time. And perhaps speak to Rochelle afterwards.
One more? Yeah. Are we out of time?
Yeah. Good one. Thank you, Terry. Sorry, I'll try to be very brief. It's very complicated, but I'm just wondering, in all of this, are you looking at iron stores in these women? Because there is old data that iron affects coagulation through platelet function, and certainly in our centre we're looking, because it's surprising in Canada today, but we have very high rates of iron deficiency, and unfortunately we're trying to get our obstetrics people to actually include a ferritin in the routine blood work for pregnancy.
Yeah.
And there's very poor adherence to guidelines re iron. So
yeah.
I think it's just another confounding factor.
So to answer the question, we're not looking at it specifically in that study, but it's not listed as a confounding factor in most of the studies that are published, but our personal practice is that we replete iron stores before delivery in all patients. So just to avoid the secondary platelet dysfunction.
I'm Sue Ann Hawes from the Canadian Hemophilia Nurses Group, and I'd like to introduce 2 of my colleagues. Dorine Belliveau is a Canadian nurse from the Nurses Group. She graduated from the Moncton University. She's had previous experience in gynecology and general surgery, as well as medical surgical ICU. She's been a nurse coordinator at the Moncton City Hospital at the Hemophilia Clinic for the past 22 years. Dorine is the current past president for our CANHC. She is a member at large on the board of directors for the New Brunswick chapter of CHS. She has worked on different committees for the CANHC as well as different projects with CHS. And with her presenting is Charlotte Sheppard. Charlotte graduated from the RN program at the General Hospital School of Nursing in St. John's, Newfoundland. She then completed her post-RN BN program at the Memorial University of Newfoundland. Charlotte has worked in many areas within the Janeway Health Centre in Newfoundland, where she is employed by Eastern Health. She has been a nurse coordinator with both the adult and pediatric patients in the Newfoundland Hemophilia Clinic since 2004. Charlotte has been a regional chair at the Atlantic Nurses Group and has worked at various committees with the Canadian Association of Nurses in Hemophilia Care and is currently a member of the program committee for CHS. So both of them are going to present a project that the Atlantic Nurses recently completed. It's a teaching educational tool called von Willebrand and Pictures. So without further ado, I'm going to let them come up and do the presentation.
Good afternoon, everybody, and thank you for sticking it out till the end of the day. I know it's a long day. My colleague Charlotte and I really want to thank the organizing committee for inviting us to present this. We're very excited to be able to present von Willebrand in pictures. The green button, I guess. So these are our disclosures for Charlotte and I. And why this teaching tool? Well, it started with me, I guess, whining and complaining that we didn't have a von Willebrand teaching tool. I used the hemophilia in pictures that the WFH has put together for hemophiliacs. I've been doing that for years. And I was using the very same tool for von Willebrand, knowing that it wasn't really specific to von Willebrands. There's a lot of information in the hemophilia binder that doesn't apply to von Willebrands. So I approached my Atlantic colleagues, and they agreed that we would get together and work on this. So we wanted to design it based on the hemophilia in pictures. So we contacted WFH and asked if we could use some of their illustrations first of all, and they agreed to that. Then we looked in the binder and saw that the company they had worked with was Image Créative from Montreal. So we contacted them, and of course they were happy to do that. So we got to work on it. Octapharma is the supporting company for this. Lydia had the idea of supplying iPads to all the clinics anyway, so she felt that this would be a good tool, because you know that kids, they love iPads and they love electronics, so the program is actually downloaded on an iPad. We have 11 clinics that have agreed to pilot the project with us, so we will be evaluating the nurse's perspective on the tool as well as the patient's perspective. So if we can get the tool up, we weren't able to break it up, but we will be very brief and just showing you quickly what the tool will look like. So the green button. This green? No, the big green button. Okay.
So this is von Willebrand in pictures. So having von Willebrand disease affects many aspects of someone's life. It is, however, possible to live an active and productive life with the help of an expert healthcare team and the tools to navigate through it all. So I'll just quickly go through and show you the content. Part 1 is Introduction to von Willebrand disease. Part 2, Common signs of von Willebrand disease. And Part 3, the treatment of von Willebrand disease and the acknowledgements. So Part 1 discusses how does blood move around the body, and the picture that's here is the same as the one in the hemophilia in pictures. And this is how does bleeding start and stop, von Willebrand role in the normal clotting process, and why do people bleed with von Willebrand disease. And you can see there's a bit of a key there. There's a red circle for red blood cells, blue for platelets. The number 8 denotes factor 8, and the black ladder is the normal von Willebrand factor, And the yellow ladder with the rungs missing is the dysfunctional von Willebrand factor and abnormal multimers. And the ladder with the yellow and black is the dysfunctional von Willebrand factor with normal multimers. So we went on to try to define what the different types were. So we included type 1, of course, type 2, type 2A, and these pictures depict those types. Type 2B and type 2N, and type 2M and type 3, which is severe. And then we talked about the genetics. How do people get von Willebrand disease? So you can see we've got a family featured there. And what happens when one of the parents has mild von Willebrands and they have children? And you can see we used like a flip of a coin to show the genetics, what happens there. And what happens when both parents with mild von Willebrands have children? What happens when a parent who has severe von Willebrand disease has children? And then how is von Willebrand disease diagnosed? So we just listed what the tests would be and what affects the von Willebrand disease results. And you can see we've got quite a few things listed there. And do von Willebrand levels change? Well, von Willebrand disease is a lifelong, most often mild condition with safe, effective treatment. And it can change over time and tends to increase with age. So if you have severe von Willebrand, your levels will not increase with age. And this is the second part, which Dorine is going to go talk about, and is common signs of von Willebrand disease.
We're kind of a tag team here. So we just go briefly over the most common signs of von Willebrand's disease, which are listed there, and then the less common signs, which some patients have to deal with. The major sites of life-threatening bleeding. And then in part 3, which is Charlotte's, I forgot to mention as well that we had all this documentation reviewed by Dr. Paula James, and I want to publicly thank her for supporting us with this project.
And this is part 3. We're talking about the treatment of von Willebrand disease, and we're looking at DDAVP and what other treatments may help, antifibrinolytics, and we didn't say which antifibrinolytic because if this gets used outside Canada, it could be another antifibrinolytic. And the treatment of nosebleeds, treatment of mouth bleeds, surgical bleeding, DDAVP prior to minor or invasive procedures, and von Willebrand factor concentrate prior to major surgeries or major trauma, antifibrinolytics as well. And treatment of GI bleeding, treatment of lacerations, treatment of muscle and joint bleeding, and treatment of heavy menstrual bleeding. And pregnancy and childbirth we've also discussed. And maintaining a healthy lifestyle, of course, is very important. And our acknowledgements. Thank you.